Hello friends. Hello friends. Now we'll be seeing a topic of that is infantile hypertrophic pyloric stenosis IHPS. So before starting, I would like to thank Chandana Shri Ma'am for sharing these wonderful notes with us, which are very helpful for quick revision. So without further delay, let's get started. The link for the notes is given in the description below. You can download it from there. So it is the disease of the newborn. So neonates which are recently born will be affected. The incidence is 1 in 300 to 900 live birth, and initially in the first to second month of life the patient will be seen and is more common in males up to 4 times. Then coming to the pathophysiology, so there will be lack of nitric oxide synthase in the pyloric tissue, so that will cause hypertrophy of the circular muscle of the pylorus, causing constriction and obstruction of the gastric outlet. So it will result in gastric outlet obstruction, and it will present as projectile non-bilious vomiting and loss of hydrochloric acid, and that will result in hypofluoremic alkalosis along with dehydration. This alkalosis will cause hypocalcemia, and over time it can cause tetany. Loss of hypochlorite, so there will be urine will be low in chloride and high in bicarbonate. So bicarbonate and sodium will be lost in urine, resulting in hyponatremia, and that will cause further dehydration. And dehydration will result in activation of RAS system, causing sodium retention, and to retain the sodium there will be urinary loss of potassium and hydrogen, causing hypokalemia and paradoxical aciduria. So this will be the metabolic picture. The clinical presentation, as you have seen, there will be progressive worsening of non-bilious vomiting. Then it will be over time, it will be increasing in frequency, it will be forceful, and it will be projectile. Visible gastric peristalsis can be seen from left to right, from the left upper quadrant to the epigastrium, and palpable olive can be seen in the epigastrium. Evaluation will be in the chest X-ray. We can see enlarged gastric bubble, USG, which is diagnostic very clearly that the pyloric muscle thickness will be more than 3 to 4 mm, and pyloric length will be more than 15 to 18 mm. Narrowed pyloric channel, that will be like the string sign, and folding of rugae, that will be double track sign. Then pyloric bulge in the antrum, which will be seen as pyloric beak or shoulder sign. You can also assess the metabolic abnormality through the ABG and the electrolyte. Apart from that, the regular pre-op workup which will be needed for the surgery. Initially, we'll have to go for medical stabilization, that is the correction of the dehydration, acid base and electrolyte imbalance, and that has to be done to prevent post-op apnea, and this has to be done pre-operatively, obviously. Then initially we have to rehydrate the baby with NS, that is up to 10 to 20 ml per kg, until the urine output adequate is established, urine output is established, and then followed by correction of hypokalemia by adding 20 to 30 milliequivalent per liter of KCl in D5 or half NS. And we have to repeat this until unless alkalosis normalizes and serum bicarb is less than 30 milliequivalent per liter. So how does this apnea occur? So metabolic alkalosis will cause decreased respiratory drive, causing compensatory retention of respiratory CO2. So that will be possible by hypoventilation and apnea. Now for surgery, we have to go for Ramstead pyloromyotomy, which can be open or laparoscopic approach. In open, there could be either right upper quadrant incision or periumbilical incision. The hypertrophied muscle of the pylorus is incised from the gastroduodenal junction to the just beyond the hypertrophic mass. So from the gastroduodenal junction to just beyond the hypertrophic mass Incision is given and is deepened by splitting the muscle fibers. Intact mucosa should bulge beyond the divided muscle edges, and then closure is done. Complication is perforation, incomplete pyloromyotomy, and feeds are resumed after 4 to 6 hours postoperatively. So this was all about infantile hypertrophic pyloric stenosis. So keep studying, keep growing, and never give up because great things take time. Please like, share, and subscribe. See you in next video soon. Thank you.